وعليكم السلام ورحمة الله وبركاته.
وعليكم السلام ورحمة الله تعالى وبركاته دكتور.
عليكم السلام ورحمة الله.
Okay, guys, as usual, 2 minutes for new members. So the curriculum is 31 chapters, and we are covering one chapter for each session as much as we can. And the exam will be online, will be 2 papers, each paper 2 hours and 1 hour break in between. You should follow the curriculum and follow also the blueprint. The blueprint will give you distribution of marks. And again, you will find clinical questions and the non-clinical questions in the exam. Regarding clinical questions, the Royal College will ask you about relevant basic sciences, epidemiology, differential diagnosis, investigation, management of this condition. And the management here, it's a broad term task, okay? They can ask you about anything. What is the initial treatment? What is the definitive treatment? What is the next step? So next step here may be investigation, maybe treatment, maybe refer or discharge, okay? So I'm talking about clinical questions. And you are emergency physician, so you have 5 chapters, very, very important. Memorize them like your name: resuscitation, cardiology, trauma, pediatric, and anesthesia. Okay, don't attend the exam without covering these chapters very well. And if you are listening to these sessions regarding these chapters, if you find any topic missed in the session, cover them in any book, in any trusted website, and so on. Okay. So from resus up to safeguarding psychosocial emergencies in children. Resus we finished already. Allergy, cardiology, dermatology, ENT, elderly care frailty, endocrinology, environmental emergencies, gastroenterology, hematology, infectious disease, maxillofacial and dental, mental health, musculoskeletal, non-traumatic, neonatal emergencies, nephrology, neurology, obstetric and gynecology, oncological emergencies, ophthalmology, pain and sedation, palliative and end-of-life care, pharmacology and poisoning, respiratory, sexual health, surgical emergencies, trauma. And today we will discuss urology. And then after we finish that, we will take break. And then we will discuss another session. It will be for vascular, number 29, okay? And again, guys, regarding the guidelines, if you find the guidelines, for example, any chapter, for example, I'm talking about acute heart failure, the guidelines like 30 pages, no worries, just read them quickly, okay? Just like you are reading a newspaper, it will not take like 10 minutes from you. Just read, don't memorize anything. What you will do, the next action. So expect the question, okay? I am posting the question in question channel, in question bank channel, okay? And I am sorry, I am not very fast, but at least I will cover as much as I can in the question bank, okay? So maybe people for the next batch, because this group for 2 batches, okay? Some people for the current batch and some people for the next batch. So I think the next batch will get benefit more, because maybe I will exceed more than 3,000, maybe more than 5,000 questions, okay? But anyway, I will do my best. I will post as much as I can. So until the exam, as much as you find any question, it will be very helpful for you. If you listen to these recordings, plus question bank channel, plus I will give you GMC guidelines and ARCM guidelines, I think you are covering everything. Okay, so sometimes 1,000 questions more than enough. But if we will post 2,000, better. If we will post 3,000, better. But what can I do? I am trying to do my best, inshallah. And also, you have different questions in the session. The questions in the end of each session different at all from the question bank questions. So be sure if you cover these sessions with these questions and the question bank and the ARCM guidance and also GMC guidance, inshallah, you are covering everything. Okay, so today for urology, we are talking about dysuria, injury to bladder, urethra testis penis, urinary retention, testicular pain, swelling, loin pain, hematuria, epididymolysis, renal stone disease, phimosis, paraphimosis, periapism, testicular torsion, prostatitis, UTI, pyelonephritis. So here regarding dysuria, what does it mean dysuria, guys?
Painful urination experience.
Okay, so the patient, if he has dysuria, so check also if male or female, young or adult, okay? And also if he has symptoms of UTI or not, he has symptoms of a stone or not. Injury to bladder, urethra, testis, penis. So what is your management here, guys? Regarding, for example, bladder, urethra, testis, penis, what do you think? What is the
It
management?
could be testicular torsion, and according to the diagnosis, like if it's testicular torsion.
Torsion here, it's a medical, it's a surgical case, not trauma, right? Testicular torsion, it's a surgical case, not trauma. But here we are talking about trauma, injury to bladder, urethra, testis, penis. Any injury, any trauma to any patient, to any site, what is your action?
ABCD.
ABCD.
ABCD,
Yeah.
done.
Yeah.
Primary survey done. Now, what is the next step? You have patient with injury to bladder or urethra or testis or penis. What is your action? Painful or not painful?
Analgesia.
Medication. Yeah.
Analgesia. What else?
To rule out the causes.
Stabilize the patient. Already stabilized in primary survey. You give already analgesia. What else?
The ruling out the causes.
Confirm.
The cause is trauma. So
decide whether to take the patient for surgical exploration.
So examination, you will do examination, you will do scan, ultrasound scan. So examination here for bladder, you will check any retention or any injury, any by inspection and also palpation. Urethra here and penis and testis, you will check for any inspection, any laceration, any contusion, any wounds. Okay, and also you will check for any bleeding from urethra. Okay, any deformity in testis or in penis. Okay, and also you will do rectal examination. And here, what is the investigation to check urethral injury?
Retrograde urethrogram.
Retrogram.
Okay, so you have to be familiar with general management. Okay, general management. General management, it means you will take history, history already in the scenario. Number 2, you will do examination, and you will do primary and secondary survey, and then you will do investigation. Investigation here, it will be workup. So workup here may be bloods, maybe imaging. Okay. So if you go step by step, everything will be clear for you. Okay. And you will refer to
urology.
our chapter urology. So you will refer to
Urology.
Urology.
So when you are study the chapter, because if you are studying cardiology, so any topic in this chapter, you will refer to cardiologist. When you are studying hematology, it means when you refer any topic, you will refer to
Hematologist.
this is how to study. Okay. So urinary retention also, you will manage the patient and then refer to urologist. Testicular pain, swelling, treat the underlying cause, and check if you will refer to urologist. Any loin pain, if loin pain only without fever, what is the most likely diagnosis?
Stone.
Stone.
That's a stone.
Pyelonephritis.
Stone
A
without
stone until proven otherwise. I'm talking about without fever. Loin pain without fever. Okay, so it's a stone until proven otherwise. But if they mention in the scenario loin pain and the fever, what is the most likely diagnosis?
Pyelonephritis.
Okay, pyelonephritis. So it's UTI. It's UTI because UTI you have upper and lower. Upper UTI we are talking about kidney. Lower UTI, for example, you are talking about bladder, urethra, and so on. Okay, hematuria may be frank. So the patient will say, I have bleeding in passing urine. So it will be frank hematuria, or maybe microscopic. You cannot see by your eyes, but you can see in laboratory. So it will be microscopic hematuria. What is the most likely cause of hematuria? Proven otherwise?
Renal stone.
Stone. Okay. It can be also UTI, it can be many things, but it's a stone until proven otherwise. Epididymoorchitis, you have to be familiar with the differentiation between testicular torsion and orchitis. Okay. Renal stone, we will discuss. Renal stone, what is the most investigation of a choice?
CTKUB.
CTKUB with contrast or without?
Without contrast.
Okay.
Without contrast.
Yeah. Anything related to urology, try to be without contrast. Anything for surgery, it will be with contrast. Okay. So if you are discussing any topic in surgery, think about CT with contrast. But urology here, try to avoid contrast because maybe he has a kidney injury. Okay. Okay, so dysuria, it's a burning micturition. As we said, maybe. Okay, urinary retention. So here, be familiar with anuria, and urinary retention. What is the difference between anuria and urinary retention?
Urinary retention is surgical.
Both of them, there is no
Anuria,
urine.
there is no urine.
Urea is a
and
problem in the
retention is that there is a difficulty of passing the urine.
Okay, urine retention, the patient is not passing urine, but he has retention. The bladder is full. So by inspection, you will find the swelling. By palpation, you will find the swelling and the tenderness. Okay, but here anuria, by inspection, the patient doesn't have a swelling, and by inspection and by palpation, the patient has no tenderness and no swelling. Okay, So here may be kidney injury. That's why any patient with urine retention, be sure that he has full bladder or not. How to do that? By ultrasound scan. So any patient with no urine, whatever retention or anuria, so ultrasound scan. It will give you idea before inserting catheter. You have to examine him before inserting catheter. If empty and insert catheter, you are exposing the patient to side effects of catheter. Maybe you will get obstruction, maybe you will get bleeding after inserting a catheter. So don't insert any catheter until you exclude retention, okay? Until you rule in retention. So urine retention, they can give you X-ray, and this X-ray, as you see, what is the finding here?
Stone. Urinary bladder stone.
Opacity here. You are talking about this one? I am talking about opacity
Yes.
in the abdomen. So opacity here because of bladder swelling, and the bladder swelling because of retention, and retention here urine. So urine is fluid, will be radio opaque or radiolucent.
Radiolucent.
Radio opaque. Any fluid, radio opaque. Okay. Air, it will be radiolucent. Air will be black, but fluid will be white. Okay. That's why here urine retention, radio opaque. Okay. So they can give you scenario, for example, patient sometimes old, for example, 65 or 70 years, so benign prostatic hyperplasia, presented with abdominal distension, pain. What does it mean, abdominal distension and pain?
Full bladder.
Urine retention.
Urine
Urinary
retention
retention.
or constipation. Maybe bowel, maybe bladder. Okay. If you find any patient in the scenario with abdominal distension and pain, think about bladder, think about bowel. Okay. Was prescribed oxybutynin. What does it mean, oxybutynin?
For incontinence, urinary incontinence.
Anticholinergic.
Okay, anticholinergic. So it will cause retention. Okay, by HGB, and it can cause constipation as well. By HGB for frequently passing urine. It means this patient, he has incontinence, for example, last 2 weeks. Okay, and he went to 2GB, he gave him oxybutynin to prevent incontinence, right?
Yes.
After that, he has side effect of oxybutynin. Despite preventing incontinence, it causes retention. Okay, so what is the diagnosis? Urine retention. 3 causes. Number 1, oxybutynin, because already mentioned clearly in the scenario, oxybutynin. Number 2, maybe the patient has benign prostatic hyperplasia. Number 3, he might have bladder or urethral stone. Okay, so this is how to think about this scenario. And your management, you will stop the medication. Any side effect for any medication, number 1 is stop the medication. So for example, the patient has bleeding because of warfarin. Number 1 is?
Stop warfarin.
Yes. Patient has blurring vision, he is using digoxin. Number 1 is? Stop digoxin. Okay. So here, number 1 is stop oxybutynin, and then urinary catheterization, UNDE, creatinine, to check if the patient has a kidney injury or not. Urine analysis. Of course, after urinary catheterization, you cannot do urine analysis until you catheterize the patient. Abdominal ultrasound should be number 2. Abdominal ultrasound should be here because you have to confirm retention first and refer to urologist. So this is opacity. Okay, they can give you another scenario. For example, 72 years old, attends your department. He has been unable to pass urine for the last 16 hours. What does it mean 16 hours? Is it acute or chronic?
Acute.
Acute.
He has severe suprapubic discomfort. So one indication for retention or one criteria for retention is very distressed. Do you think if he has anuria because of kidney injury, he will get suprapubic discomfort? Or
No.
he will be
No.
very distressed?
No.
He managed 2 drops for the triage nurse when he asked urine sample. So they can ask you about important examination, prior catheterization, and why. So this patient, you have to do digital rectal examination. Why, guys?
To rule out BPH. Benign
BPH,
prostatic
excellent.
hypertrophy.
Excellent. What else? Why digital rectal examination?
Can be constipation also.
Posterior. Posterior.
To rule out neurological deficits. Maybe the patient has urinary retention because of neurological deficit, right? Maybe he has Kodai-Koino syndrome.
Rectal tone, yeah.
Okay, so digital rectal examination for prostate, for benign prostatic hyperplasia, and also to rule out any neurological cause. And
Before
then,
or after?
BR tenderness, perianal tone sensation, this one. Okay, so this one also included in digital rectal examination. He's catheterized after that and has a residual volume of 1.6 liters. Over the next 3 hours, he passes 230, 300, 250 ml of urine. So first hour, 230, second hour, 300, third hour, 250. And he has a residual volume in the start, how much?
1.6.
1.6.
It's too much, more than 1 liter, too much, okay? And when to say oliguria?
Less than 5.
Less than 0.5 ml per
0.5
kilogram per
per
hour.
hour. Per hour.
So, for example, he is 70 kilogram. 70 kilogram. So, how much?
35 should be.
Excellent, 35 ml per hour, right? Can you imagine? You are expecting he will pass urine almost 35 ml per hour. Now he passed 230. Too much or not?
Yeah. This is too much.
Yeah, first hour too much, second hour too much, third hour too much. So almost how much total? 1.6 and 800. So it's almost 2.4 liters. The patient lost 2.4 liters from his body. Is it too much or not?
Yes, too much.
Too much.
Too much.
Pretty much.
The patient lost 2.4 liters per 3 hours. Can you discharge this patient?
No, he will get
No,
dehydrated.
we're going to dehydration.
Yeah, dehydration.
At home, he will pass the same. Okay, so the patient will die. That's why any patient, you will insert a catheter at least between each hour. You can clamp the catheter, okay, and give fluid also in the meanwhile. So what does it mean, and what is your action? So this is called post-obstructive diuresis. Post-obstructive diuresis. Can you imagine, guys, if you will put hose in a bottle and this hose will transfer water, it will not stop. Clear? If you are putting a hose between 2 bottles, the water will go from this bottle to this bottle. Why? Because it's connected. That's why this is called post-obstructive diuresis. Maybe for several days, the patient will lose urine and the fluids for several days. This will cause hypovolemia, and this is possible. So the action here, admission, you will do serial U and E, strict fluid balance. So you will check fluid in and the fluid out. So after catheterization, they can ask you about documentation. Documentation here will be procedure and history. What important factors must be documented in his notes regarding this procedure and his presentation that will guide short and long-term management. What does it mean short? What does it mean long? Short now and the long-term management, if the patient will come later, so your colleague will find, for example, you inserted 14 catheter. So already you know the size. Your colleague after 1 month, you know the size also. Okay, you inserted the catheter with difficulty. So your colleague after 1 month, he will understand it was difficult, and so on. Okay, so you will document the procedure, you will document ease of procedure, type and size of catheter, okay, and the history, why the patient came, for example, frequency, nocturia, hesitancy, previous urological surgery, constipation, or the underlying cause. You will document all the history. I mentioned the most important points, but anything related to a procedure, anything related to the history, you will document. Testicular pain and swelling, so maybe torsion, okay, maybe the patient has a virus, okay, maybe the patient has varicocele, maybe hydrocele, maybe trauma, maybe spermatocele, maybe inflammation like epididymitis or orchitis, maybe tumor. So one by one, torsion, what do you think, guys? They will mention in the scenario, what are the criteria in the scenario?
Axial charismatic reflex, and one touches will lie about the other.
What is the age group first in the scenario?
Young
Older.
patient.
Young,
Younger age.
11 years
30.
old,
Up to
11
30.
years old, 16 years old.
14.
Okay, up to 30 years, for example, or up to 35. Okay. And the patient may be also, he has a sudden acute. Okay. And also maybe he has same problem before, same previous episodes, and recovered spontaneously. Okay. So virus, the patient, he has previous flu symptoms or anything, or he has a history in the scenario for virus. Varicocele, so we're talking about veins. Hydrocele, we are talking about fluids. Trauma will be mentioned clearly in the scenario, the patient has trauma. And inflammation, the patient, for example, he has cheek swelling. They will mention the patient is young and he has cheek swelling, so maybe mumps. After that, he has orchitis or epididymitis. Tumor, it's unlikely in the exam, but if they ask you what is the serious differential diagnosis, so what will you say? Tumor. And of course, the patient will have constitutional symptoms. So if they ask you about testicular torsion, the most common in the exam, testicular torsion, epididymitis. If they ask you what is the differential diagnosis, the common differential diagnosis, if it's not torsion, what do you say?
Epididymitis.
Okay, it depends on the age. We will see now. So differential diagnosis of unilateral testicular or scrotal pain and swelling may be abscess, epididymitis, Cornelius gangrene. So this one specific, and they will give you image. Henrichon line berbera, unlikely in the exam to give you testicular pain and they ask you about Henrichon line berbera. Herschel and Barbaras, they will give you rash, hydrocele, inguinal hernia, or chitis, may be referred to pain from renal colic, testicular cancer, testicular torsion, torsion of appendiceal testis or torsion of appendix, trauma. So what is the diagnosis here?
Corneas gangrene.
Corneal gangrene.
Yes. So this one, I think it's obvious. If they give you this image, you can diagnose easily. Necrotizing fasciitis affecting external genitalia or perineum. So it can extend to the perineum. Risk factors, like any infection. Risk factors, same. IV drug user, the patient has diabetes, malignancy, liver cirrhosis, vascular disease, using alcohol. So drug or alcohol. Steroid also because it will affect the immunity. Chemotherapy, morbid obesity, HIV, immunosuppression. The clinical features, the patient has this image and he has fever, systemic upset, swelling of scrotum or perineum, sudden pain in the scrotum or perineum. Pain typically extends beyond the border of demarcated erythema. Necrotic patches appear in the overlying skin as the condition progresses. Foul smell and infected necrotic tissue. Crepitus can occur. Guys, can you hear me clearly?
Yes.
Yeah. Causative organism, so aerobic and anaerobic bacteria. So if they ask you direct question regarding the causative organism, Clostridium perfringens, or group A Streptococcus, Staph aureus, Vibrio magnificus. So remember that. Treatment, so IV antibiotic and the debridement of necrotic tissue. So for you, if they ask you about initial treatment, what do you think?
Pain, analgesia.
Analgesia and
IV antibiotic.
IV
Antibiotic.
antibiotic.
IV fluid.
And refer to?
Urology.
Urology.
Okay, but if they ask you what is the definitive treatment?
Antibiotics. and
Debridement of necrotic tissue.
Yes, debridement of necrotic tissue. Okay, hematuria, it can be gross hematuria or microscopic. So source of hematuria, as you know, we will talk about urinary tract. So any site can cause hematuria. Kidney can cause also ureter, bladder, prostate, urethra. So kidney may be glomerular cause like glomerulonephritis, nephropathy, extraglomerular like benign or malignant renal tumor. The patient has benign or malignant tumor, polycystic kidney disease, sickle cell disease, pyelonephritis, stones, renal papillary necrosis, maybe trauma. Ureters, maybe tumor, stones, stricture, infection, trauma. Urinary bladder, so maybe also benign or malignant tumor, stones, infection, chronic irritation, trauma. So if you think about all, you can think about tumor in any site, stone in any site, infection in any site, trauma in any site. Okay, and here prostate, benign prostatic hyperplasia, cancer, trauma, urethra, infection, trauma. Bladder cancer affect around 1 to 5,000 people. Rare or common?
Common.
1 in 5,000.
Rare.
Rare.
Is rare.
Okay. And 3 times more common in men than in women. It means if happened in every 5,000 people, 1 person may be male. Okay. 90% transitional cell carcinoma. So this is a histology or pathology. Risk factors include smoking, if they mention in the scenario smoking. Smoking is the risk factor for any cancer. 50% of male and 25% of female bladder cancer cases are thought to be due to smoking. Exposure to aromatic amine, people who are working in rubber, leather, textile factories, urinary stasis, if the patient has schistosomiasis. Bladder cancer can present with macroscopic or microscopic hematuria. So if the patient has in the scenario frank hematuria, so it's cancer until proven otherwise. Even in OSCE, guys, remember that. Sometimes the patient has hematuria, painful or painless?
Painless.
Painless. Painless. Okay. So the patient has painless frank hematuria and he's concerned to go home, just to give me medicine and to go home. You will discharge?
No.
No. Okay. The patient has painless hematuria and he has old age, so it's cancer until proven otherwise. Don't discharge. Okay. So it can be macroscopic or microscopic. It can be painless or painful. So if macroscopic and painless, don't discharge them. Maybe pelvic or loin pain and symptoms of recurrent UTI. So if the patient has symptoms of UTI, don't give him antibiotic and discharge. Okay. MSU can usefully exclude UTI and help in detection of microscopic hematuria. Referred urgently, so you refer urgently. Diagnosis usually occurs following biopsy, cystoscopy. So it can be a question. This one can be a question. This one can be a question. So your management is refer urgently. And here the investigation of a choice, biopsy, cystoscopy. Diagnosis and the treatment involves transurethral resection of the tumor, curved, with intravesical chemotherapy. Remember that. Epididymolysis, it can be infective or non-infective. Epididymolysis is inflammation of epididymis and or testis. So can be acute if the patient attend with 1 or 2 days, chronic if the patient attend after 6 months. Infective causes, if the patient male under 35 years of age. Okay, so think about infection, think about sexual transmitted infection, think about what?
Gonorrhea, chlamydia.
Gonorrhea and chlamydia.
Chlamydia and gonorrhea. Remember that. If the patient under what?
35.
In the scenario. So if the patient in the scenario, male over 35 years of age, think about infection also. But here it will be
Non-STI and
non-sexual.
E. coli.
It will be non-sexual. So under age of 35 in the scenario, think about sexual transmitted infection. Chlamydia, Neisseria. If the patient more than 35, think about non-sexual transmitted. So it will be UTI. And any UTI, think about Escherichia
E.
coli.
coli.
What about 15 to 30? You think about
Mumps orchitis.
orchitis. Okay. You will take sexual history in all age group. So if the patient come, whatever, from 15 to up to 35 or more, so you have to take sexual history to exclude what?
Sexually transmitted disease.
Yes. Non-infectious causes, if they mention in the scenario, the patient has surgery, history of surgery, like genital or urinary surgery, whatever, prostatectomy, vasectomy, urinary catheterization. He has catheter 1 week ago, he has catheter 1 month ago. So think about non-infectious. Basic disease, sarcoidosis, drug-induced. The patient is using amiodarone. So it can be epididymolysis, but non-infectious. Clinical picture, usually unilateral, scrotal pain, erythema, swelling, pyrexia, urethral discharge. Okay, remember that. Differential diagnosis, the most likely differential diagnosis is
testicular torsion.
yeah.
Testicular torsion.
So check sign, brain sign. It means elevating the scrotum on the painful side. The patient has problem in the left side, for example. So you will elevate the scrotum of the left side. And it can help to distinguish between epididymitis and the testicular torsion. Elevation of the scrotum will do what? Relieve pain, but not torsion. Okay, so if the patient have been relieved, so what is the diagnosis?
Epididymitis.
Epididymitis.
Okay. Treatment, it depends on it's infectious or not infectious. Okay, and it depends on the patient if infectious, sexually transmitted or non-sexual transmitted. Okay, so I want to say sexual transmitted, less or more than 35.
Less
Less than
Less than
30.
35.
Okay, so here, if you will see the patient less than 35, it's a sexual. So gonorrhea, for example, you will give ceftriaxone 1 gram IM a single dose plus doxycycline 100 milligram orally twice daily for 10 to 14 days. After that, refer to sexual health specialist for follow-up and contact tracing. Advice to avoid sexual contact during a treatment and until his sexual partner have been traced and treated. Okay, what else to avoid? Blood transfusion. Treatment if non-sexual transmitted infection. So we are talking about Escherichia coli. So the age more than
35.
35.
okay. So you will give ofloxacin. So if you find the patient in the scenario his age more than 35, think about non-sexual transmitted. If they ask you about the treatment, ofloxacin 200 milligram orally twice daily for 14 days, or ofloxacin 500 milligram orally once daily for 10 days. If aquinolone is contraindicated, so you will give coamoxiclav 500, 125 milligrams 3 times for 10 days. Avoid in people with hepatic impairment or history of hepatic dysfunction associated with coamoxiclav due to associated risk of cholestatic jaundice. What are the general measures? The patient has epididymolysis. So general measures before or after antibiotic?
After.
Before and after.
Before.
Before and after. So bed rest, scrotal elevation, such as with supportive underwear. Analgesia will help alleviate symptoms, and then give antibiotic and advise the patient to do the same. For example, if they give you patient 12 years, brought by his mother, presented with unilateral cheek swelling. So what does it mean, cheek swelling?
Mumps.
Mumps.
Mumps sarcoidosis.
Yeah, 5 days complaining today with testicular pain. What is the most likely diagnosis? So mumps and complicated with bronchitis. Here, in SPA, they can ask you about only one most serious differential diagnosis. So serious here, testicular torsion, testicular tumor, incarcerated hernia. So what is the most serious of them?
Testicular torsion.
Torsion. Because more than 6 hours, it's gangrene. Okay. Okay. One investigation to confirm the diagnosis and why. So you will do Doppler ultrasound tests. Why? To assess blood flow to post-test to rule out testicular torsion. Okay, so regarding acute and severe loin pain, you will think about urinary stone or renal colic if there is no fever. Okay, so caused by urinary tract stone obstructing the flow of urine. Severe unilateral abdominal pain originating in the loin or flank, radiating to the labia in women, or groin or testicle in men. So once you see that in the scenario and no fever, so think about renal colic, and it will be constant or on and off.
Colic, on and off.
Colic pain, it will be on and
Colic
off.
on and off.
Yeah, and the sudden, for example, 30 minutes, 1 hour, and so on. But if the patient has 2 days, it means it's infection, right? The pain typically lasts minutes to hours and occurs in spasm, intervals, no pain or dull ache. Note the vomiting in the scenario. Hematuria may be in the scenario. Most severe pain experienced. The patient will say the worst pain. The patient restless, cannot lie still, but if the patient has UTI, whatever upper or lower, he will be restless?
No.
No. Which help differentiate renal colic from peritonitis, may have history of previous episodes, may present with fever and sweats if concomitant urinary infection is present. So it can be renal colic with infection. With fever. May complain of dysuria, urinary frequency strain when the stone reaches the zygomatic junction due to stone irritating the detrusor muscle. So what is the diagnosis here?
Renal stone.
Stone.
Adhan
Renal
calcula.
stone. Stockholm stone, yes.
Adhan.
Staghorn calcula. Staghorn calcula.
Okay, Staghorn calcula. So don't offer antispasmodics to adults, children, and young people with suspected renal colic. The majority of Staghorn calculi are radio opaque. You know, sometimes people, even urologists in some hospital, they are offering antispasmodics like Buscopan or anything because they have idea this will dilate the ureter and it will lead the stone to pass, but it will cause severe pain. Okay, so the most important in renal stone, analgesia. The majority of Staghorn calculi are radio opaque, as you see, white, composed of magnesium ammonium phosphate, strobite. Remember that. Untreated, it will cause renal destruction and significant morbidity mortality. So remember that any patient with Staghorn should be removed urgently. You can use medical expulsive therapy, so calcium channel blocker and alpha blocker, tamsulosin. Remember that. It will relax ureteric smooth muscle, enhance stone passage. Percutaneous nephrolysotomy, this surgery, it's not our duty. So the treatment of a choice of Staghorn calculi. So if they ask you what is the definitive treatment, you can choose percutaneous nephrolysotomy. But if they ask what is the initial treatment, you can give analgesia and medical expulsive therapy. Extracorporeal shockwave lithotripsy, this first-line treatment for a small renal stone. So here, if they ask you about definitive treatment, you will check the size. Okay, if it's small, you can use extracorporeal shockwave lithotripsy. But if large, like Staghorn calculi, so percutaneous nephrostomy. Open surgery for renal calculi, this is the last resort for complex cases only. Diagnosis, urine dipstick, testing to support the diagnosis and look for evidence of UTI. So this initial diagnosis or investigation of a choice?
Initial diagnosis.
Yeah, initial. So you can do urine dipstick. If you want to do also ultrasound, it's okay. But the investigation of choice, of course, non-contrast helical CT. This one replaced IV urography. Before, the investigation of choice, it was IV urography, but now non-contrast helical CT. So here, UTI, it can be in urine dipstick. So we will check for hematuria. So this one, diagnosis of renal or ureteric polyp. Check for nitrite, leukocyte esterase, such as infection, and investigation of choice, as we said. Then plain abdominal X-ray of the kidney, ureter, bladder. So X-ray KUB. Renal tract ultrasonography, MRI, retrograde ureterography, so magnetic resonance urography, retrograde ureterography, ureteroscopy. Pain management here, non-steroidal anti-inflammatory drugs, whatever, rectal or IM, any route, no problem. So if they give you in the exam non-steroidal or any other painkiller, it choose non-steroidal. So non-steroidal or opioid, guys, which one you will choose?
No steroid.
Non-steroidal. Okay. If they give you options for rectal and IM and IV.
Rectal.
Rectal. The priority for rectal. Okay. So by any route, as first line treatment, all ages. IV paracetamol, if non-steroidal anti-inflammatory drugs are contraindicated or not giving sufficient pain relief. So the patient has pain score 7 out of 10, 7 out of 10, and the non-steroidal given, and the patient is still in pain. So what is the next action?
Opioid.
Opioid.
Why opioid?
IV paracetamol.
Paracetamol. So again, IV paracetamol if non-steroidal are contraindicated or not giving sufficient pain relief. Okay, so what is the second line?
IV paracetamol.
IV paracetamol. Please remember that. Opioid, another scenario. Opioid if both. So what is the third line? Opioid. If both non-steroidal and IV paracetamol are contraindicated or not giving sufficient pain relief. Okay. So this one can be questioned, this one can be questioned, this one can be a question. Okay. Okay. Phimosis and paraphimosis. So here, be familiar with that. The glands, foreskin, and the penis. Here, in Candida balanitis. So this is a healthy one. It will be without redness, without inflammation, without discharge. If infected, so you will find redness, okay, for the glands. You will find rashes, it's called blotchy rash. And you will find discharge, okay, discharge from urethra. So 3 points, redness, rash, discharge. So be familiar with this definition. So phimosis, it means a stenosis of perpetual ring with inability to retract the foreskin. So if you cannot retract the foreskin, it's phimosis. Retention of retracted foreskin in a position proximal to the coronal sulcus, paraphimosis. Balanitis, as we said, is this one. So inflammation of foreskin. Bursitis inflammation of the glands. So this is the foreskin, this is the gland. So inflammation of foreskin, it's called balanitis. Inflammation of the glands, it's ascites. Inflammation of urethral meatus, this meatus, so meatitis. So balanitis, it's a clinical diagnosis, inflammation of the end of the penis, the glands, often occurring with inflammation of the foreskin too. Most commonly affects boys aged less than 4 years of age. So you will find the scenario within 4 years. And those have not been circumcised. So circumcision here, it's important to avoid infection. Circumcision, important to avoid infection. Clinical picture, as we said, redness, irritation, soreness of the glands, may be impossible to pull the foreskin back, and there may be dysuria. So what are the causes? Poor hygiene, phimosis, non-retractile foreskin, dermatological conditions, the patient has psoriasis, maybe he has infection, candida, allergy. Diagnosis, because we are talking about discharge also, so a swab may be taken if the diagnosis is uncertain. Treatment, the opposite, so good hygiene, gentle cleaning of the area. Clotrimazole, remember that, may be used if candida infection is suspected. Mild steroid cream to reduce inflammation and redness. If phimosis is causative factor for recurring balanitis, then circumcision may be an option. So he can do circumcision later. Periabism, condition number 4. So the patient presented to ER with periabism, what you will do? It's very painful and dangerous. Very painful and dangerous. So here, don't inject near these areas. Okay, so don't inject here or down, up and down. So you can inject in this area only. So what is this area, guys?
Corpora cavernosa.
Corpora cavernosa.
Yeah. So here it's called corpora cavernosa. Okay. This is the urethra. Okay. This up, down, up, dorsal, ventral, and lateral. So you can insert butterfly here, as you see, and withdraw blood. It will release the blood and it will release the periabism. So what are the causes? Okay, so maybe hematological cause. The patient has sickle cell disease, thalassemia, thrombophilia, hereditary spherocytosis, G6PD deficiency. Any blood disease can cause that. Why? Why, guys?
Because of stasis.
Viscosity.
Bleeding inside the corpora cavernosa, right?
Yes.
Congestion, engorgement of bleeding. Okay, so here sickle cell disease can cause thalassemia, thrombophilia, hereditary spherocytosis, G6PD. Malignancy, like leukemia, it can cause bleeding. Genitourinary malignancy, brain tumor. Neurological disorders like multiple sclerosis, spinal cord compression, syphilis. Trauma, so pelvic trauma, it can cause periabism. This one neurological cause, trauma, neurological cause. And the neurological cause also because of neurology. Infection, like a scorpion sting, patient has malaria, rabies. Medication, the patient is using antihypertensive, anti-anxiety, anticonvulsants, antidepressant, vasoactive medication. That's why most people who are taking depression medication or psychotic medication, they have periabism. drugs, alcohol, cocaine, marijuana, thrombotic disease states, asplenia, erythropoietin use, cessation of comadine therapy, metabolic disorder, if the patient has gout, amyloidosis. So they can ask you about periodism. It's a common question. So if they ask you about the initial conservative measures, local anesthesia of the penis, insert white bore butterfly. So anesthesia first because it's painful. So anesthesia first local and then insert white bore butterfly through the glands into the corpora cavernosa. Aspiration, cavernosal blood until bright red arterial blood is obtained. And then irrigation, cavernosal irrigation, 0.9 saline. Intracavernosal therapy, you will inject, already you released the blood and you released priapism. After that, you will inject adrenoceptor agonist. So what is the current first line therapy? Phenylephrine. Okay. Injected every 3 to 5 minutes. Maximum dose is how much?
1 mg.
1 milligram within 1 hour. So you will inject phenylephrine after release of periodism. Then it will be 3 to 5 minutes, maximum 1 milligram within 1 hour. Surgical therapy, if failed, surgical shunting, consider primary penile implantation if priapism has been present for more than 36 hours. So another question, another scenario, if they mention in the scenario, the patient, it's a difficult, the pain will let the patient to come even within 1 hour, okay? It's unlikely for patient to come after 36 hours until he's ashamed. And of course, because of severe pain, he will go to ER. So surgical shunting, consider primary penile implantation if priapism has been present for more than 36 hours. Testicular torsion. So the test here, blood flow is normal. That's why the test is normal color. Here, the test is twisted on its axis. That's why no blood flow to the test. That's why there is a change in color. And once you do Doppler ultrasound, you will find this test with normal blood flow and this one with decreased or absent blood flow. So you will do Doppler ultrasound for one test or both?
Both.
So,
Both. To compare, maybe the patient has in both sides, maybe he has in one side, okay? So any patient presenting with acute, severe, sudden onset testicular torsion until proven otherwise. And also in the exam, any scenario for testicular pain, I will not say acute, severe, sudden onset. I will say any patient in the exam with testicular pain, it's a testicular torsion until proven otherwise. Symptoms, you will find symptoms in the scenario, sudden onset, severe pain, maybe vomiting in the scenario, maybe occur during sleeping, maybe during playing football. Half of torsions occur during sleeping. Previous history of torsion to the other tests. So previous episode. Previous history of less severe episodes that have resolved in recent past. History of undescended tests. So any patient, for example, 1 year in the scenario or in practice with undescended tests, he has testicular torsion.
Testicular torsion.
If they mention the patient doesn't have testis after labor, or he has one testis, so he has undescended testis and the most likely testicular torsion until proven otherwise. Signs. Test lies high in the scrotum. It can be in the scenario, or the examiner can ask you by different way. He can tell you which of the following signs support your diagnosis. So if you find test lies high in the scrotum, choose. Test too tender to touch, choose. Opposite test lies horizontally, so it's called angel sign. Pain not relieved by elevating test, brain sign. Absence of cremasteric reflex. The most important sign here is
Absence of prismatic reflex.
excellent. Absence of cremasteric reflex. They can mention in the scenario any of these signs and ask you which of the following signs can support your diagnosis. Testicular torsion, surgical emergency, require urgent assessment and immediate intervention to restore the flow of blood. Irreversible ischemia begins around 6 hours. Remember that. So is it reversible or irreversible?
Reversible. Until 6
Reversible.
hours when it becomes irreversible.
Yeah, so it's reversible. But if more than 6 hours, irreversible. Sometimes it's until 12 hours reversible. Sometimes until 24 hours, it's reversible. But unlikely. Okay, it's a high risk to be irreversible. High risk to be gangrene. But some cases, even in our hospital, after 12 hours up to 24 hours, is still alive. A spermatic cord twist, it can cause ischemia. Age group for testicular torsion, 15 to 13 years. Be familiar with varicocele, hydrocele, testicular cancer. It's unlikely for the exam, but be familiar with that. So varicocele here, collection of varicose veins. We are talking about veins in the uniform plexus of the cord and scrotum. More frequently in the left test. So likely to be in the scenario left test may be associated with infertility. The leg in the test that is often worse after exercise. So if they mention this happen after exercise, think about varicocele or at the end of the day. So if they mention that in the scenario, think about varicocele. Treatment, conservative, with surgery being used in severe cases. So mild to moderate cases, varicocele. So it will be conservative. If they mention severe case, so it's a surgery. Hydrocele, collection of fluid in tunica vaginalis, scrotal swelling, ultrasound to exclude tumor. So any patient with hydrocele, do ultrasound to rule out tumor. They are often managed conservatively unless large. So mild to moderate will be conservative. Testicular cancer, the most common malignancy affecting men 20 to 34. 20 to 34. So unlikely in the exam, but if they give you the age 20 to 34 and constitutional symptoms, the patient has weight loss, loss of appetite, night sweats, iron deficiency anemia, fever, mild to great fever, and testicular pain, think about testicular cancer, but unlikely in the exam. Risk factors include undescended testes. So any patient with undescended testes may be testicular torsion, may be testicular cancer. Paleness, testicular lump, paleness, constitutional symptoms. Surgical treatment, plus minus chemo and radiotherapy is the mainstay of treatment. So if they give you age 20 up to 34 and lump, testicular lump, constitutional symptoms. So here, surgical treatment, choose this option, plus minus chemo and radiotherapy. So they can give you, for example, patient with 14 years, acutely painful, acute, painful, red swollen scrotum. So it's a testicular torsion until proven otherwise. After examining the patient, clinical suspicion for testicular torsion is equivocal. What does it mean, equivocal?
Could be.
Suspected.
50-50.
50-50. Excellent.
Yeah.
Okay, so equivocal here, the ultrasound did not give you any benefits. Okay, you still have suspicion, but ultrasound normal. So here you have to confirm by examination. Okay, you have to refer to urologist. What is the investigation of a choice after that?
Ultrasound for blood.
Sound.
Now, is this one ultrasound already? Okay, so here clinical suspicion is equivocal, so your examination is 50-50, and you did ultrasound also equivocal. So what do you think? What is the next investigation?
CT.
Surgical exploration.
Arthrography.
What do you think, guys?
Surgery.
Assess the blood
Surgery.
flow.
Surgical scrotal exploration.
Surgical exploration. Yeah, surgical exploration. Surgical exploration here, therapeutic or diagnostic or both?
Both.
Both.
Okay, so it's a very easy surgery. Just do exploration, just one, and check. You will see by your eyes if twisted or not. If twisted, what you will do?
Untwist and
Untwisted. Untwisted.
Untwist.
It's very easy. Okay, so here number one, examine. Number one, history. Number one, history. Okay. Number one, history means the symptoms. The patient will say blah blah blah. Number two, examination, signs. Okay, so if examination equivocal, okay, you cannot diagnose, so you will go for ultrasound. If ultrasound give you clear diagnosis, so refer to urologist. If ultrasound equivocal, so here's the next step will be by urologist also surgical scrotal exploration. It will give clear diagnosis. Okay, so two signs to confirm testicular torsion. If you find in the scenario ipsilateral loss of cremasteric reflex, it choose. Ipsilateral tender test retracted upwards, it choose. What is your investigation? What is the definitive investigation? Your investigation here, initial investigation in ER, it will be Doppler ultrasound to check the blood flow to test. But definitive investigation, it will be surgical scrotal exploration. What is the definitive treatment?
surgical exploration.
Surgical exploration.
And
Untwist.
excellent, untwist. So what is the difference between investigation and treatment? You have to reverse the torsion. Okay, so here Doppler ultrasound initial investigation and in definitive investigation surgical scrotal exploration to assess blood flow to both tests regarding Doppler. I'm talking about Doppler. Most common diagnosis if there is no torsion. It depends on the age. Okay, so if the age in the scenario up to 11 years, so what is the most common differential diagnosis?
Appendix torsion.
Yeah, so any patient with testicular pain, so it's a testicular torsion until proven otherwise. So you did ultrasound, there is no torsion. So what is most likely? Appendix torsion. Okay.
Appendix torsion.
So from 12 to 16, same appendix torsion. From 17 to 40, what is the most likely diagnosis if no torsion?
Epididymitis.
Okay, so if they ask you what is the most common differential diagnosis if no testicular torsion or if testicular torsion rolled out, okay?
Appendix torsion.
So think about appendix torsion until age
17.
17. Okay. So if the scenario, the age is less than 17, it's appendix torsion. If the scenario more than 17, so think about epididymitis. Okay, so we will go for our scenario. What is the age?
14 years old.
So what is the most common, if no torsion?
Appendix torsion.
torsion appendicular torsion.
If they give you,
Appendix torsion.
yeah, the alternative name, okay. So appendix torsion or torsion of testicular or epididymal appendage. So if you find this one, choose. If you find this one, choose. Okay. Prostatitis, causative organism, Escherichia coli. As we said, anything related to urinary tract, Escherichia coli. Also can be streptococcus.
Hey, Dr. Hani.
Yeah.
Sorry to interrupt you. Dr. Hani, can you tell me about the blue spot? I have one question in the last my exam. They give a scenario. There's bluish spot in the scrotum.
Again.
In my last exam, the scenario gave me the blue spot in the scrotum.
Blue dot sign.
Blue dot. Yes, blue dot.
Blue dot sign.
Yeah. Blue dot sign. Yeah.
Yes.
It will be appendix torsion. Okay. Okay. So if they give you a blue dot sign, so it's a specific for appendix torsion. And is it serious or benign condition? Appendix torsion.
Benign.
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 Benign condition. Okay. So regarding prostatitis, Escherichia coli, the prostate is usually involved as a consequence of maybe a spread from posterior urethra or urinary bladder. That's why the patient has prostatitis. Maybe he has blood or lymphatic infection. Maybe he has rectum infection. So any patient with prostatitis, it can come from urethra, bladder, blood, lymphatics, rectum. NICE guidelines suggest that acute prostatitis means we are talking about how to diagnose from the scenario. So they will mention in the scenario, the patient has feverish illness, sudden onset, maybe associated with rigors, arthralgia, myalgia, irritative urinary voiding symptoms. So you will find in the scenario dysuria, frequency, urgency, or acute urinary retention, perennial or suprapubic pain. So the patient has penile pain, low back pain, pain on ejaculation, pain during bowel movements, tender prostate on rectal examination, urine dipstick show white blood cells, urine culture confirm UTI. So this is how to diagnose prostatitis. If you find any of these, so think about prostatitis. Treatment, ciprofloxacin 500 milligram twice daily or ofloxacin 200 milligram twice daily, first line. Okay. Or if they are unsuitable, try misoprene 200 milligram twice daily. Levofloxacin 500 milligram once daily or cotrimoxazole 160 milligram twice daily when there is bacteriological evidence or sensitivity and a good reason to prefer combination to single antibiotic. This is second line. So think about first line, ciprofloxacin. Clinical symptoms of UTI. So patient has dysuria, suprapubic tenderness, urgency, hematuria, increased frequency of micturition, polyuria. So management of UTI in general, 3-day course of trimethoprim or nitrofurantoin. Remember that I'm talking about in general. Mild symptoms of UTI, if you find 2 or less symptoms that are classical for UTI. So if you find 2 or less of these symptoms, it's mild symptom. Dipstick should be utilized to help guide diagnosis and treatment. Clinical features in patient 3 months to 5 years, they are not talking. So any patient 3 months to 5 years with vomiting, poor feeding, lethargy, irritability, abdominal pain, or tenderness, urinary frequency or dysuria, think about UTI until proven otherwise. NICE gives the following guidance for the treatment. Men with lower UTI. Lower UTI. What does it mean, lower UTI, guys?
urinary bladder,
Bladder, urethra.
urethra.
Okay. So cystitis or urethritis. So immediate antibiotic prescription to men with lower UTI take account of previous urine culture, susceptibility results. So you will check the record of the patient before giving antibiotic, check his previous culture and susceptibility results. Previous antibiotic use will help you, which may have led to resistance bacteria. Obtain midstream urine sample from men before antibiotics are taken and send for culture susceptibility testing. The choice of antibiotic for men with lower UTI. So first choice, trimethoprim, also nitrofurantoin. So you will use 200 milligram BOPD for 7 days. When to use nitrofurantoin? If mentioned in the scenario, GFR more than 45 ml per minute. So if they did not comment about eGFR, you can use trimethoprim. If you find eGFR in the scenario, think about nitrofurantoin. Second line, if they mention no improvement in lower UTI, on first choice for at least 48 hours, or when first choice not suitable. Second choice, which one, trimethoprim or nitrofurantoin?
Nitrofurantoin.
Okay. NICE give guidance for treatment of women with lower UTI. We finished men already. Now we are talking about women, but here not pregnant. We will discuss not pregnant, and then we will discuss under 16 years. So consider backup antibiotic prescription to use if symptoms don't start to improve within 48 hours or worsen at any time, or immediate antibiotic prescription for women with lower UTI who are not pregnant. So in men, what you will do, you will give antibiotic, but you can consider these factors. It will be immediate, right? But here in women, what you will do, consider these factors, but you can give delayed prescription. After how many hours?
48 days.
48 hours.
48 hours. It means you will ask the non-pregnant woman, you can tell her, take this delayed prescription, but don't take now. If symptoms worsen within 48 hours, you can take. Okay, so take account of the severity of symptoms, risk of complication. Check the patient has the structural abnormality in urinary tract, whatever, for example, kidney problem, ureter problem. I'm talking about structure, anatomical, or functional abnormality. It means the patient has impairment. 1 second. Or the patient has a function problem, for example, impairment, UTI, or kidney injury. So you should think about these factors, okay? Or immunosuppressed. The evidence for backup antibiotic prescription, which was only a non-pregnant woman with lower UTI, where immediate antibiotic treatment was not considered necessary. Previous urine culture, you have to check this factor also, and susceptibility results. Previous antibiotic use, which may have led to resistant bacteria. References of the woman for antibiotic use. So you should consider these factors before giving antibiotic, and giving antibiotic in a woman will be immediate or backup. The choice, first choice will be nitrofurantoin or trimethoprim. Second choice, it will be nitrofurantoin, also with mesylamine, fomycin. So here, regarding first choice, nitrofurantoin, 100 milligram modified release BOPD for 3 days. If they mention in the scenario EGFR more than 45, trimethoprim 200 milligram BOPD for 3 days if low risk resistance. What about second choice? So no improvement in lower UTI on first choice for at least 48 hours, or when first choice not suitable. So you can go for second choice. NICE give guidance for treatment of young people under 16 years with lower UTI. Under 16, remember that. So what you will do, if they mention in the scenario, female patient with symptoms of UTI, for example, dysuria, frequency, lower abdominal pain, and. So what you will do, obtain urine sample before antibiotics are taken and the dipstick test. You will send for culture and susceptibility. Immediate antibiotic prescription for children and young women under 16 years with lower UTI. Take account, so you will check previous urine culture, susceptibility results, previous antibiotic use also. If urine sample has been sent for culture sensitivity testing, when antibiotic prescription has been given, review the choice of antibiotic when microbiological results are available. So children under 3 months, you will refer to pediatric specialist and treat with intravenous antibiotic in line with the NICE guidance on fever under 5 years. So here, if the patient has symptoms of UTI and he has fever, you will follow fever under 5 years, traffic light system, you remember? So first choice in children over 3 months, and second choice in children over 3 months. So nitrofurantoin, if they mention EGFR in the scenario more than 45 ml per minute, trimethoprim if low risk resistance. Second line in children over 3 months means no improvement in lower UTI symptoms on first choice for at least 48 hours, or when first choice not suitable. So you can use nitrofurantoin if EGFR more than 45 ml per minute and not used as first choice if not used. Amoxicillin if nitrofurantoin is chosen. So you can use amoxicillin only if culture results available and susceptible. Otherwise, you can use cephalexin. Admission, when to do admission? More serious illness or condition, for example, sepsis. The patient has a lower UTI and the patient as well, is unwell. So you can admit the patient. Marked signs of illness in the scenario. Or the patient pregnant. So any patient, lower UTI and pregnant, you will admit. NICE also recommend considering referral or seeking specialist advice, are significantly dehydrated, unable to take oral fluids and medicines, pregnant, higher risk developing complications. Who are at high risk for complication? People with known or suspected structural or functional abnormality of genitourinary tract or underlying disease, such as diabetes mellitus or immunosuppression. Have a recurrent episodes of UTI, for example, 2 or more episodes in 6 months. So remember that when to admit when to do referral and or specialist advice.
Dr. Hane,
Yeah.
please, that means fever is not an indication for admission here, because there was a question you posted like that, indication for admission, and you put fever and pregnancy as part of the option. And in the end, you choose fever.
This one?
Yes, one question in the question bank like that. Indication for admission. In the options, there was pregnancy, there was fever, and some other options. But in the answer, final answer, you choose fever.
So you mean fever is one of the criteria to admit?
Yes.
Yes, marked signs of illness. Systemic the patient is unwell.
Okay. But in this case now, there is fever and pregnancy. In that option, you put fever and pregnancy. So fever is more important than pregnancy, right?
If the patient has fever, the patient is unwell, it will be clear. They will give you something obvious in the scenario. The patient has, for example, nausea, vomiting, fever, cannot tolerate oral. So it will be admission. They will give you something obvious. Okay.
Okay.
Yeah. UTI, pyelonephritis, the recommended choice of antibacterial therapy for non-pregnant women and the men. Okay. So again, so oral, first line. We finished lower UTI. Now we are talking about lower or upper?
Upper.
Upper. Okay. So condition number 7, we are talking about UTI, pyelonephritis. We are talking about upper. We finished already lower. The recommended choice for antibacterial therapy for non-pregnant women and men, both of them. So here, oral first line cephalexin. So what is the most serious, upper or lower? Upper. So first line cephalexin, ciprofloxacin, or if sensitivity is known, amoxiclav or trimethoprim. So here, sometimes you are giving drugs, and if you find a specific culture, so you can change the antibiotic according to the culture. What is this called? When to give, for example, antibiotic, general, you are following the first line, and once you find sensitivity, you will change to, for example, amoxiclav. So what is called? Stewardship antibiotic. Okay, so you are following stewardship guidelines. Okay, I sent in the group, and if you search by stewardship guidelines, they will give you what to do with antibiotic. So intravenous first line, if severely unwell, okay, or unable to take oral. So if they mention in the scenario, the patient has nausea, vomiting, the patient has fever, maybe also hypotension. So think about intravenous first line. Amikacin, ceftriaxone, cefuroxime, ciprofloxacin, gentamicin, any one of them. Amoxiclav is in combination or sensitivity known. Intravenous second line, consult local microbiologist. The recommended choice of antibacterial therapy for pregnant. So we finished the non-pregnant and the men, now pregnant. So oral first line, same, cephalexin only, okay. Intravenous first line, if severely unwell or unable to take oral treatment, we are talking about pregnant, but intravenous. Cefuroxime, remember that. I know these guidelines, it's difficult to memorize from the first time, but if you will make notes, paper, it will be easy for you. And at least remember the first one and or second one. Intravenous second line or combining antibacterial if concerned about susceptibility or sepsis. So here, consult local microbiologist. What is the single most likely diagnosis?
Epididymoarchitis.
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 Okay.
Corneas
Corneal
gangrene.
gangrene.
Option
Corneal
D.
gangrene.
Excellent. Single most likely diagnosis.
Testicular cancer.
Testicular cancer.
Okay, so he said here painless, firm swelling.
Painless.
Single most likely diagnosis.
Varicose.
Infertility.
Okay. Single most likely diagnosis.
Bladder cancer.
Bladder cancer.
Okay. Single most likely diagnosis.
UTI.
Option.
Option 2.
Option 2, urinary tract infection.
Okay, upper or lower?
Lower.
Lower. Suprapubic tunnel.
Likely causative organism.
Neisseria gonorrhea.
Option 4.
Neisseria gonorrhea. Okay. Following is most appropriate treatment.
Trimethoprim.
Ceftriaxone plus doxycycline. Option 3.
Ceftriaxone and doxycycline. Option C.
Okay, so what is the diagnosis?
Epididymoarchitis. STI.
Yes, agree.
Okay, so here less than 35, right?
Yes.
It means sexual transmitted infection. If more than 35,
Ofloxacin, quinolones. Non-STI.
okay, which of the following is most appropriate treatment?
Ofloxacin.
Option 3.
Oflox.
Okay, what is the diagnosis?
Epididymoarchitis.
And is the age more than 35?
Non-STI.
Following is most appropriate treatment.
Levofloxacin.
Option 3.
So 62, 5-day history of acute left side scrotal pain fever. Epididymis tender and swollen. Overlying scrotal skin is red and warm to touch. Elevation of scrotum relieves the pain. What does it mean, relieves the pain? What is the sign?
Sign.
So what is the diagnosis?
Burn sign.
Epididymoarchitis.
Epididymoarchitis.
He is known to suffer from epilepsy. What does it mean?
He's an
Antibiotic medication.
antipsychotic. Yes, antipsychotic.
Okay. So why here coamoxiclav?
Because there is drug interaction, levofloxacin with phenylephrine.
Risk of cholecystic.
Ciprofloxacin is contraindicated in seizure.
Okay. Single most likely diagnosis.
Epididymoarchitis.
Epididymoarchitis. Option A.
Most likely causative organism.
E. coli.
E. coli.
E. coli. Option C.
More than 62 years
More
old.
than
following analgesics.
Diclofenac.
Diclofenac number 1.
Okay, which route?
Rectal.
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 Magnesium ammonium sulfate.
Magnesium ammonium.
Magnesium
Last
ammonium
option.
phosphate.
Argon.
Argon.
Non-contrast helical CT.
Option E.
Last
Option E. Non-contrast.
Okay. Unable to take
Intravenous.
non-steroidal.
Intravenous
Paracetamol.
paracetamol.
Second.
Option 2, IV paracetamol.
Okay. So second line. So if paracetamol and the non-steroidal.
Opioids.
Opioids.
Take the third
Morphine.
option on morphine.
Option 3, alpha blockers.
Tamsulosin.
Okay.
ESWL.
Option E. Option D.
PCNL. PCNL.
Okay.
What does it mean, most appropriate management? Definitive.
Like a definitive. Like a
Definitive
definitive.
management.
Definitive.
Definitive management.
Okay.
Yes.
The best.
Treatment
The
of
best
choice.
management. So here you have to check the size. Is this one is small or large?
Large.
So
Large.
percutaneous nephrolysotomy. If it's small.
Lithotripsy.
S ولا
Lithotripsy.
Option D. Extracorporeal shock regulated.
Okay. Single most likely. Diagnosis.
Nephrolithiasis.
stone.
Stone.
Option 3.
Understand.
And here also.
Yes.
Single most likely diagnosis.
Balanitis.
Option A, melanitis.
Option unable to
Okay.
Option A.
Okay, because he said complaining of pain, end of pain. Red, crying when trying to pass urine means dysuria. Red swollen. Unable to pull or scan. Single most likely diagnosis.
testicular torsion.
Torsion. Testicular torsion.
Testicular torsion.
Why?
Extremely tender and
Yeah,
little
the
higher
patient-
than the left side.
Because
higher than
acute onset.
Acute onset, severe
Severe.
pain.
severe pain.
Young
Okay.
patients
Nausea,
just woke
vomiting.
up,
Nausea,
lactose,
vomiting.
nausea, vomiting, very hard, painful, and
Tender.
a little higher than the other side.
Higher than.
Yeah, and a little higher than the left side. Single most likely diagnosis.
Testicular torsion. Charismatic.
Testicular torsion.
Because the cremasteric
Okay.
reflex is absent.
Because he said severe,
Pan
painful,
white green.
swollen, acute means a sudden onset.
While
He was sleeping, and it means specific. Okay, and also vomiting, tender to touch. Cremasteric reflex absent.
Dr. Hani,
Yeah.
I'm sorry, I have a question with this. The next step in this patient with this criteria would be referral to urology or do an ultrasound. Which one in this criteria that you mentioned?
Yeah, good question. Good question. If the patient from the examination, I'm talking about the examination, equivocal ultrasound. If the patient from examination highly suspected urology, clear?
Okay, yes, clear. This one I think urology directly.
Yeah. So from this scenario, this one from examination, from this scenario, is it equivocal or highly suspicious?
Highly
Very high
suspicious.
suspicion. Very high
So
suspicion.
what is the next action?
Urology directly.
Referral.
Urology. Urology. But if, for example, they said the patient has acute painful swollen right testis only, do you think it's highly suspicious?
No.
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 Still,
If they
yeah,
ask
this
about
is
the next action, it will be
that need ultrasound.
Double
after that.
ultrasound.
Okay. Yeah.
which of the following antibiotics is recommended by NICE first line treatment? 63 male. Is it lower or upper?
Lower.
Lower.
Tender prostate.
Lower, yeah.
Lower.
Afloxacin.
Afloxacin is prostatitis.
Quinolones.
Ofloxacin.
The same scenario, but we don't have ofloxacin.
Ciprofloxacin. Yeah.
Okay, so I will go back to the other scenario, the same. Okay, but we don't have a question for ofloxacin. Clear, guys?
Yes.
Which of the following antibiotic is recommended by NICE as first line? So check first the age, check male or female, check upper or lower. So 63 male, so tender prostate. He has been advised to not take quinolone antibiotics due to previous side effects.
Or
amoxicillin.
Trimethoprim.
Okay. Suggested duration of treatment of this condition, acute bacterial prostatitis.
14 days.
14 days. 14 days.
14 days. Okay. Single most likely diagnosis.
Prostatitis, I think.
Prostatitis.
Prostatitis.
Bacterial prostatitis.
Single most likely diagnosis, done already. Okay. Single most appropriate management option.
Last option.
3 days.
3 days. 3 days course.
3 days
Yes, 3
course
days.
of oral trimethoprim.
Simple UTI.
Single most appropriate management option.
Uh,
29 woman, so above 16, and also pregnant or not. Today history.
Not pregnant.
Not pregnant.
So start her on the 7-day course of nitrofurantoin.
So option,
Third option.
yeah, urine dipstick test to help in this patient diagnosis. Okay. Which of the following antibiotic is most appropriate to prescribe in this case?
Nitrofurantoin, number 1.
GFR is high, more than 45.
Yes. Which of the following antibiotic is the most appropriate to prescribe in this case?
Option 4.
Trimethoprim,
Trimethoprim option.
Phos, I think.
Oh,
Phosphine, yeah,
phosphine.
this one.
Oh,
Yeah.
okay.
Also, GFR, yeah.
Which of the following antibiotic is most appropriate to prescribe in this case?
Amoxiclav. GFR is
Trimethoprim. 5-year.
Yeah, pediatric.
Which of the following clinical feature is not stated by NICE as being suggestive of UTI? 4-year.
Urinary frequency.
Urinary frequency.
Hematuria.
Hematuria.
Okay. Which of the following is not an indication to consider admission to hospital in a patient with pyelonephritis?
Failure to improve significantly with 12 hours.
Option 4.
Option D.
4.
Option
Okay.
4.
Should be 48 hours.
48
48
hours. not 12 hours.
48 hours, yes.
Okay. So, Dr. Osman, I think the other options, it will be indications.
Yes.
So, more than 38, pregnant, significant tachycardia, dehydration. Clear?
Yes, boss.
Thank you, guys. Inshallah, we will take break.
Thank you,
And
Dr.
then, yeah, we'll come.